Welcome back to Core Anesthesia. Whether you are a student prepping for tests and boards or a CRNA here to earn CEUs, we are glad you've joined us. For more about us, make sure to check us out on Instagram at Core Anesthesia and online at coreanesthesia.com.
Welcome back to Core Anesthesia. I'm Cole, here with Tanner, and today we are excited to continue our discussion on all things OB. We've done several episodes in the recent past about obstetrics and all that goes into that. It's a very niche-specific form of anesthesia, but it's also a very complex form of anesthesia. And so we're really excited today to bring on another guest speaker. I'll let Tanner introduce him here in a second, but we could think of nobody better to bring on to talk about all things in terms of adjunctive medications that you might be adding into your neuroaxial anesthesia, specifically in the OB world. So your epidurals, your spinals, and then also some different types of blocks that we can also do when you have patients that may not be getting that neuroaxial anesthesia.
Yeah, like Cole said, there's nobody better that we could bring on. And I feel kind of silly introducing you, Tom, because if you know who we are, then you for sure know who Tom Baribeault is. So, but anyways, we'll still introduce Tom. Tom Baribeault. He is the founder of SOFA, the Society of Opioid-Free Anesthetics, and he's published on these topics. And so we just thought it was really great to be able to bring him on tonight. Lengthy experience working with obstetrics, and we're really excited to have you here, Tom. So thanks for joining us.
Yeah, thanks for having me. It's always a good time here at Core Anesthesia.
We love it. I know that Cole, of the two, Cole is the guy that's working OB far more than I am, but I still, dabble in it here and there, and I know the pains that we go through in dealing with obstetrics. And it's like, I feel like you have a like Cole said, it's a niche kind of avenue of anesthesia, and you have CRNAs that love it, and you have a large group of CRNAs that absolutely can't stand it and would never touch it. And I feel like there's just some common things that you might see in the OB world. You've got patients that you either can't control their pain or you can't control it well enough, or you've got patients that are feeling nauseous while we're having low blood pressures, and you're holding the puke bag while you're also trying to keep them calm. And there's just a lot of different, nuances within the OB world that maybe you don't see when you're sitting in your chair doing a lap chole and comfortable with the bear hugger on you. So some of those things that we're hoping that we can talk about tonight, about how we can address those things, how we can maybe provide a more effective path forward compared to maybe some of the traditional ways that we've done OB anesthesia in the past. So I guess my first question to start would be, when you're kind of dabbling in some of these adjunctive medicines that you're trying to improve patient experiences, what are some of the key things that you're seeing that led you to be like, hey, there's an issue here, maybe we could do this better?
I think that no one goes into anesthesia because they like talking to people, right? And and I think that's like one of the challenges of obstetric anesthesia is the anxiety that the patients have. And, with just our sort of tradition of doing these procedures on patients with them wide awake and not sedated, there's a high level of anxiety involved. And that can sort of cloud the issue when you're trying to assess how well your block is working sometimes. The way we give local anesthetics with a little bit of opioid, they do really good for sharp pain, but they're really poor at controlling that visceral referred pain. And whether that's the pressure when they're 8, 9, 10 centimeters and delivering vaginally, or if you're in a C-section and the surgeon, extroverts the uterus, and like you said, all of a sudden the patient's puking on your shoes, and you're trying to like hold the bag for them while like reach back to your drawer and get some medications out and push them one-handed. Right. There's things that, those medications, the way we have always done it, do really well, but there's definite gaps. And And, there's sort of two paths you can take. You can go, well, it just is what it is, and the results fall out the way they will. And we're going to have high rates of patients who are uncomfortable and vomiting and all those things. Or you can, try and do something about it.
You hit on a good point there. So I work at a teaching facility, and we have a lot of anesthesia personnel coming through and training on the OB floor. And I always start off first day when I'm teaching them that they often come with this expectation that this is going to be an anesthetic where I'm in my call room for a lot of the time. And then when I get called, I come out and I just quick do an epidural, or I'm going to do a spinal for a C-section and then just kind of sit there while they close the patient up after the baby's out. And I explained day one, it is so much more than that because of the fact that you're managing those epidurals, you're managing the transition pain that they have. You're in a C-section, trying to not only provide anesthesia, but you're providing verbal anesthesia because, as you said, they're a wide awake patient, very different than the other forms of anesthesia that we are typically providing. And so there's a lot more that goes into this. And so to your point, how can we best take care of these patients? Is it just continuing to do what we've always done? Or is there a better way to better take care of these patients from a all around standpoint? Um, and I think I always tell everybody verbal anesthesia is huge in OB. You have to have that presence, that calming presence to deal with not only the patient but then the families that are with them. But then two, are there better ways, especially during C-sections? For me, it was always as a new anesthesia provider on the OB floor. How do you handle the referred pain you talked about when their uterus is out? They're closing that up. The baby's screaming a couple feet away, and mom is having horrible shoulder pain. She feels like an elephant's on her chest. She's puking. You're trying to manage hemodynamics. It's not just sitting there blissfully for a few minutes when you got moved out from your call room. And so, to your point, there are definite gaps in the way that we've always done it, so to speak, that we could improve upon to provide a better outcome for the patients.
Sure. And, I think we'll go ahead and just talk about pain and anxiety right now, because that is probably one of the things that's the easiest thing for us to take care of, by adding a little bit of Precedex into our spinals and our epidurals. And that works, when they're delivering vaginally or by C-section. We've all been in that situation where the patient's like has an OP baby. You come, you give a bolus, it gets better for an hour, and then you get called back an hour later and they're uncomfortable again. And like that goes on all night long and you don't get any sleep from it. And so I think just providing uh better analgesia makes you a safer provider, lets you get a little bit more sleep as well.
Why does that always happen at night too? It's never during the day that that's happening. It's always in the middle of the night that it's every hour you're getting
About
called.
yeah, 3 a.m., man.
So you're a big fan of using Precedex. That's your first line of an adjunctive medication to add in? Or I guess first of all, what epidural drip are you using as your base? And then we'll talk about kind of what we're adding into that.
I've done both bupivacaine and ropivacaine, and honestly, I can't tell a difference between the two. I know you'll find some people out there that swear one is better than the other. Standard concentrations, 8% bupivacaine versus 0.2% ropivacaine. And the other side of that is, I'm not a nurse trying to get this patient positioned and rolling them every half an hour. So the degree of motor block really doesn't affect me as an anesthesia provider. But what I find is that facilities and OB units have very strong feelings about it. They've at some point decided on one or the other, and they like it. And so I'm willing to roll with whichever one that facility likes. I'm not going to make waves and try and change that. I will say that one of the things about labor epidurals is you always have to make sure you have enough volume, because there's three things that can happen, right? You can not have they can be hurting because you don't have enough volume, in the epidural space. They can be hurting because you need a stronger concentration or a stronger drug in the epidural space. And they can be hurting because the epidural is migrated out and needs to be replaced, right? So if you've got three variables and you're trying to, diagnose what the problem is, three variables is too many. So the thing I do is I take volume out of it. I make sure absolutely that there's enough volume in there. I run my drips at 12 mLs an hour. And the PCA bolus gives a 10 ml bolus. Okay. And then if I'm going to come in and I'm going to give a bolus, I'm going to give a 10 ml bolus. So I've only got two variables to deal with. If I get called to give a top off dose because someone's in pain, the issue is they either need stronger medication or I need to replace the epidural. So I'm going to bolus it once. If it's better, fantastic. If it's not better, it needs to be replaced. I'm not going to give a little bolus, come back 5-10 minutes later, give another little bolus. One bolus, if it's not working, we're going to replace the epidural. But you have to make sure that you have enough volume in the epidural space. So that's just key number one.
Yeah, that's a great point, Tom, in terms of if you can eliminate variables, then you're able to better diagnose and fix the problem. I think especially so many people I talk to get called back 3 or 4 times as they're continually trying to figure out the problem. And so if you can minimize the variables that are potentially at fault, you're going to be able to diagnose that quicker and get a patient more comfortable quicker, which then also allows you to either be taking care of other patients, because there's usually multiple patients at once this is happening to, at least in my experience. Or two, to your point, you can actually get a few hours of shut-eye so that you're better prepared when that crash section comes or things of that nature. So let's say now you have a patient, you have plenty of volume, you've been running it for 6 hours or something like that, and all of a sudden now you're getting called to go to the bedside. Maybe the nurse has given 2 boluses recently. What do you try to add into that? Like when you're going to give a top off dose, are you just giving more of the same volume you're already giving? And when you say you're giving a hand bolus, what are you providing extra that they would not be getting if you're just simply giving a bolus off of the pump?
So the number one thing that you need to do is give a higher concentration of local anesthetic, right? Obviously, what's in your infusion isn't adequate uh, to control their pain. So give a higher concentration. So if it's 8% bupivacaine or it's the middle of the night and you just want this bolus to last as long as physically possible, go up to 0.25% bupivacaine. Or if you're running ropey, you just like ropey, whatever, you can also do 0.5% ropey. But the thing you need to understand is that 0.25 bupivacaine and 0.5 ropey are kind of equivalent drugs. Bupivacaine and ropivacaine aren't equivalent analgesics at the same concentration. So you need a higher concentration of ropivacaine than you would bupivacaine. But either 0.25% bupivacaine, 0.5 ropey. Again, I use 10 mLs because I want to make sure there's adequate volume in there. And then I also add 25 mics of Precedex to my bolus. And that does a couple things for us. Number one, it's going to prolong the duration of the local anesthetic I'm giving them. So it's going to make that last at least 3 hours, sometimes a little bit longer. So it's really going to prolong the duration of the bolus you're giving. And hopefully get them through this hump. Most of the time they're about 8 centimeters when this happens. Hopefully this will get them all the way through delivery. The other thing that Precedex does is it's really good at treating that visceral pressure that local anesthetics are not good at relieving. So the pressure from the baby pushing on the pelvis that's causing this intense pain at 8 centimeters. It is excellent at taking care of that. And then the other thing it really does for you in that situation is it provides some anxiolysis for the patient as well. And so, obviously, I'm never going to be pregnant. I'm never going to have to push a baby out. The thought of doing that makes me anxious, though. Like, and we all know the loop between anxiety and pain. If you're anxious, you feel your pain a lot more strongly, or any of these sensations that may not necessarily be painful, they're just intense pressure. When you're anxious, your brain starts perceiving that as painful. So if you can take that anxiety away, the patient's going to be able to tolerate discomfort a lot better.
Now, with these boluses, Tom, have you ever seen any issues with sedation? I know it's a small dose that you're giving, but obviously we want to take away anxiety, but we also want them to be a participant in the birth story and a participant in, what's going on. So have you had any issues with people saying that they felt groggy or felt like they weren't able to participate the way that they wanted to? Or do you feel like it's just enough to take the edge off of anxiety and also, obviously, like you said, treating the visceral pain and things like that? um, and you just see the benefits.
Yeah, so yes and no. So do you see patients get sleepy after some Precedex? Yes, you do. Not, I mean, I've never had someone completely obtunded from that dose. The other really nice thing about Precedex is, one, it's not an amnestic, right?
Mhm.
So they're still going to remember everything while they're awake. But two, it just mimics the natural sleep pathway. And so the typical thing when someone's sleeping because they've gotten some Precedex, you kind of tap them on the shoulder, say their name, and they wake up, right? So they're always arousable.
Yeah.
Um,
And how
so
many times?
yeah, I do see people sleepy occasionally. The other thing is, like, when they've been in labor for how many hours, are they sleepy because of the Precedex, or they sleepy because they're exhausted and you just took their pain away?
Yeah.
And maybe it's a little bit of both, but I've never seen this, like, profound, they're just out, go for a head CT because you're worried what's going on
Yeah.
type
Yeah.
of
Yeah.
situation.
I was
Yeah,
literally just going to say that, where like, how many times do you actually get their pain under control and they go to sleep anyways? Because, like you said, they've been laboring and it's like finally the pain gets under control. They get a little nap before, the final push. And yeah, so I can understand that'd be kind of a tricky distinction. I tell people that all the time when I drop off into PAC, even for like general surgeries, if I've given Precedex. Yeah, I want to make it explicitly clear that this is not a patient sleeping off like narcotics, where they're obtunded or they're just super groggy. I'm like, they are sleeping on Precedex. So if you talk to them, um, they'll wake up and they'll talk to you right back. And it's not like, but if you leave them alone, they'll probably lay there and take a nice nap, and you could delay PACU times by, a ton if you just let them lay there and sleep. But they'll be more than happy to wake up and talk to you if you, like you said, tap them on the shoulder and talk to them. I think that's one of the beautiful things about Precedex. And it just makes sense. Like we use it all the time in other avenues of anesthesia. And now we're talking about a specific population that, just as we began the episode, we were talking about how critical it is to manage things not only from a pain standpoint, but, talking them through the procedure, what's going on, managing the anxiety. And it's like, if you could write a billboard for Precedex, you're like, this is it. These are all the things that it does. And so it just makes sense, to be adding that in. Now, will you bolus that as well? Say you are going to top off an epidural to go back for a section. Will you do the same thing by adding Precedex in there as well?
Do, and I use a little bit bigger of a dose when I'm going back for a C-section. I'll typically do 50 mics going back for a C-section, and I'm comfortable doing a little bit of a bigger dose at that point because, one, you're gonna have surgery, so we need stronger levels of analgesia, we need stronger levels of anxiolysis, um, but two, like, I'm gonna be right there with the patient, so, if their heart rate does dip a little bit or whatever, any sort of weird problem, I'm gonna be right there with them for the next hour, so, um,
And the beautiful
and
thing
also
too, you're not giving this IV, right? It's not like you're going direct systemic. This is going into a space that can get absorbed intravascularly. So that's why it's nice that we're there. But theoretically, as long as you're aspirating, you're not going to have, or do you still see that significant drop in heart rate like you were if you were giving a larger IV bolus?
I don't. You know, sometimes I will see the heart rate, slowly drift down and into the 60s or 50s and it always responds well to Robenal or ephedrine if you need it. Um But just, from a basic safety standpoint, I don't know that I really wanna be giving large doses of Precedex and then, like, leaving the room with an OB/RN monitoring the patient, not on telemetry, you know?
Yeah. Okay, so you're giving that as you're entering the OR, or do you give that, 5-10 minutes before you're heading back, or I guess in terms of onset, when have you seen in your experience is the best time to give that? Do you need some time for it to build up, or is it 5 minutes and they're ready to start?
Yeah, so that there's a lot of variables there to sort of talk about. Starting with just how quickly do the nurses on your unit move, right? When they call you for a C-section, is it like, in half an hour to an hour, we're going to go back to the operating room? Or do they forget to call you until they're in the operating room?
Yeah.
Um, so I would say if it's that first situation where you've got half an hour or greater, I will get my long-lasting, very dense, local anesthetic, point 0.5 bupivacaine. Um, I'll give 10 mLs of that with 25 mics of Precedex, right then and give that time to start working. And then I'll give another 10 mLs of that with another 25 mics of Precedex when we get to the OR. If it's like the situation where, I'm going to drop the drugs, go push it, and we're rolling, or, you know, even better, like they're crashing through the doors of the OR and you're just trying to like unlock the Pyxis. I'm just gonna shove it in then and use a short acting local anesthetic. I've really started left lidocaine behind and I've been using 3% chloroprocaine and I don't think I'll ever go back. And that's another beautiful thing about adding Precedex to it is when you've got a short acting local anesthetic and you add Precedex to it, it's going to last about 2 hours now. So you've got something that has a fast onset that actually has some duration to it. You're not going to have to push the chloroprocaine and then, half an hour later, push some bupivacaine or whatever to get through the end of the C-section.
Yeah, makes sense. Now, what volume are you giving for the chloroprocaine?
When you've got an epidural, the volumes are always the same. Um, you know, it's just what medication you're using. So
Sure.
I don't think I've ever used less than 15. Um, 20 is probably the most common dose. And again, I know some people get away with, oh, I only use 10 mLs. But I think I'm big into preventing problems, and so I would rather give a bigger bolus up front and do my best to ensure that they're not going to have pain during the surgery. Because what happens is the dermatome you need for the uterus is higher than the dermatome you need for the skin incision, right? So they cut through the skin, the muscle, everything's fine until they make that uterine incision to get the baby out, and all of a sudden the patient's having pain. And that's the most critical part of the surgery, when you need to be ready to start the Pitocin. And then you're going to have swings in heart rate and blood pressure from the Pitocin, and the patient's hemorrhaging, and you're giving TXA and extra uterotonics, and the patient's throwing up because their uterus is extroverted, and all this stuff is happening right then. So I want to make sure that whatever local anesthetic I give has an adequate volume and an adequate time to reach its peak effectiveness by the time they get to the uterus. And that's why um, I'm using a short acting, fast onset local anesthetic anytime I don't have at least half an hour, prior to.
Yeah, definitely. Before we get into talking about other adjuncts or talking about spinals specifically, one more thing on epidurals. Adding the Precedex, one of the points you made is that it will prolong the anesthetic, or the whatever dosage you're giving it, basically will prolong the duration of action. Have you had any issues with that prolonging, I guess, too much, where people are have delivered and it's just taking a while to regain motor and all that kind of thing?
Yeah, absolutely. And I won't say it happens commonly. And when I found when I was adding it to the infusion a lot, I would have that problem commonly. And definitely it's worse with bupivacaine than ropivacaine. I think that's one area where the motor sparing effects of ropivacaine is really beneficial. If you're gonna add Precedex to your epidural infusion, definitely I would say preferentially use ropivacaine. I've kind of the way I minimize that happening is, if I am going to put it in the infusion, I'll just put it in the first bag. And then if you're just using it in your top off doses, really doesn't tend to be, there's enough time, right? Um, by the time you're getting called for a top off dose, the patient dilates another centimeter or two and actually delivers the baby. Um, you might get burned if, like, the patient's 10 centimeters and refusing to push unless they get a bolus and a little more analgesia. But I think at that point, you could use a short acting local anesthetic. You could use some lidocaine or chloroprocaine in that situation. I think the big thing is, as long as it doesn't happen too often, you're not going to have issues, right? Because even when you don't use Precedex, you have these weird patients that are just extra sensitive to local anesthetics, and their spinal or their epidural takes a long time to wear off. That just happens. And so, as long as you're keeping your dose of Precedex kind of to the doses that we discussed, you're not putting it in all your infusion bags. It's pretty uncommon for that to happen, but it may once in a while. But what I find is the nurses are so appreciative that your boluses work so well, that if you do have one that lasts a little bit longer, they're okay with it. Or sometimes I'll even give them a heads up. When you have those really difficult patients, the super anxious ones, the history of chronic pain or opioid abuse, that, their nervous system is sensitized and they're having a hard time um, getting comfortable, you say, look, I'm going to do this thing. It's going to really help their pain, but their block may last a little bit longer, right? You have that discussion and let them know. But as long as it's in the minority of the time, it's not really much of an issue.
Yeah, I like to usually tell the patients if I'm giving a Precedex bolus, especially if they're like 8 centimeters. I tell them, hey, this might make your legs a little bit heavier, just so you know. It's gonna if there's anything that's gonna take away this pain, this is the best drug I have for you right now. And they usually appreciate that more than the fact that they can't move as much. But to your point, I try to be very cognizant about if they are about ready to push, right? I'm not going to come give a big bolus of Precedex to your point, right? But other than that, in my experience of giving Precedex, I don't see it last. But like you said, about 3 to 4 hours typically is when I see that the really dense part of that block. And to your point, by the time they dilate all the way, push a baby out, and then have the recovery time, it typically does not last any longer, at least from my experience. But I have not added Precedex to my infusion bag to start. So that's actually very interesting. I've always come and given it as a top off dose rather than adding it. And we use bupivacaine. We don't use Ropib. So I would be curious if we would ever start using it in infusions. So you recommend switching to ropivacaine if you're going to do that?
Absolutely. And you know what I wonder about, and this is just, my brain. Um, there's a little bit of literature out there on using chloroprocaine infusions for epidurals. And typically in the setting of they're allergic to amides, right? They're allergic to bupivacaine and ropivacaine. And you can use chloroprocaine, in that setting. But I wonder if running a chloroprocaine infusion with some Precedex and it wouldn't just be like the sweet spot.
Mm-hmm. That's a great point.
But
Have,
I don't think that'll ever happen.
yeah. Have you had a number of patients where you've had that amide local anesthetic allergy that you've had to do that before?
We've probably done it once or twice, maybe. But and I think at least one of the times I was pretty skeptical of their story, but they said it. So it
Hmm.
was like, sometimes you're just looking for an excuse to try new things.
Right. For sure.
The dentist told me I'm allergic to local anesthetic. All right.
Yes,
You know,
exactly. Uh,
um, that sort of thing.
so I guess we can kind of shift now from epidurals to a scheduled C-section if you're going to be doing a spinal. Um, or I guess before we jump to that, is there any other adjunctive medication that you like to add besides Precedex, or should we talk about that when we get into C-sections? Is there anything else with the epidurals you want to discuss?
Lately, I've been putting a lot of Decadron in my spinals, and I've put it in the epidurals both for labor and for C-sections as well. But I've been not nearly as impressed with that as I have been giving the Decadron intrathecally. So we can talk about that in a second.
I had one more question before we moved on. I know I said that was my last question before we moved on, but I lied.
Just
So
Tanner all through school, okay?
yeah, exactly. You said that you moved from lidocaine to chloroprocaine, and you don't think you'll ever go back. What are you seeing the difference there that makes the difference?
It's two things. It's onset and its density. 3% chloroprocaine just has a noticeably faster onset and density. And, you know, theoretically, it's a safer drug as far as maximum dose goes. You can give about a third of an ml per kilo of chloroprocaine, but only a quarter ml per kilo of 2% lidocaine. So, you know, again, theoretically, you can only give an 80-kilo patient 20 mLs of lidocaine, and you can give a 90 or a 60-kilo patient 20 mLs of 3% chloroprocaine. So it's just a little bit safer as far as the toxic dose goes. But really, it's just the onset and the density of it.
Or
I've pretty much used 2% lidocaine primarily for my conversions into sections, and I've been wanting to switch into chloroprocaine. And actually, just this past week, I did my first section using that. I was doing an epidural on one of our fellow CRNAs actually, and it was at the
Wait,
very end of my 24-hour shift. I mean, I this is like less than 10 minutes to go in my 24-hour shift, and I'm placing the epidural. I just put it in. I was giving the test dose and I was going through my spiel, let me know if you have any of these symptoms in the next 30 seconds. And the door burst open and the charge nurse comes in. Her eyes are wide and she's like, I need you now. Like, get out of the room right now. I need you. And so I just rip off the drape and I throw the catheter over her left shoulder. And I just looked at the nurse and said, you got to tape this up. And I sprinted out of the room. And they were flying back with another patient that I had an epidural on, that they were crashing the mom because baby's fetal heart tones were down significantly for the last 10 minutes. And so I didn't want to have to put her to sleep because it had to be delivered right away. So I want to give her the best chance of staying awake. And I'm like, this is my chance to use chloroprocaine. And I did that with, I think I did 20 mics of Precedex with it and didn't need anything else. She did awesome. Now I didn't see the end of the case because it was at the very end of my shift, but the onset was so much faster than the 2% lidocaine. The block was dense enough. It was totally fine. And it went great. So I'm definitely going to start using that, I think, more for those quicker conversions into a C-section.
I have one more question. Man, you're going to kick me off this podcast.
liar. Double liar.
Goodness.
I know, double liar. No, are you ever using it as like a top-off dose? I know that people kind of shy away from using lidocaine just, like while they're doing a top-off just because it's going to be such a dense block. But are you ever using that if you have somebody that you really are having a difficult time controlling the pain with the epidural, that you would give that not going to section, just on like a routine epidural, or you reserve it mostly for going back to a section?
I mostly reserve it for going back to section. I could see an instance where, the patient is literally complete and just needs to push, um, and, needs some additional analgesia at that point. I could see doing that. I would probably dilute it down 1.5, 2%. I probably wouldn't do 3%. Where I have used it is for laceration repairs, where they've either turned the epidural infusion off to help the mom push better, or whatever reason the epidural's worn off, but they still have to sew up a laceration. And so they call you to come bolus. I absolutely use it for that.
Yeah, makes sense. All right, I'm done with questions. Cole, you can move on. You can move
Hallelujah.
on to the
Okay. Let's move on to the second part of this episode, which is C-sections now. So for a typical spinal, how are you dosing that? What are you adding in? Again, this is typical section. We'll talk about general cross sections without neuraxial next, but in a patient you're going to do a spinal on, what is your routine dosage and what medications are you adding into that for this procedure?
Will say this sort of about my approach and myself. I am not a subtle anesthesia provider. And especially in OB, like we talked about, you've got anxious people, and the thing that really hit me, I was talking to a patient during a C-section once, and she was talking about how she could feel their hands inside of her. And that just skeeved me out, right? I can't imagine that. And we have this constant refrain. We're always telling people you're going to feel touch and pressure, but nothing should be painful. It To me, it would be intensely disconcerting to feel people rummaging around my abdomen, right? Um, and so from that point forward, I don't want to say I um, overdo it, but I really try and maximize the amount of analgesia that I give patients. If I can make them feel absolutely nothing, that is my goal. And the other thing is, kind of like my our conversation about having three variables be too many. When I'm approaching how I give a spinal, um, I only want one problem, right? And there's some people who try and dose their spinals a little bit lower to prevent hypotension, right? But when you do that, you can't guarantee that you're not going to have hypotension. So you can't eliminate that problem, but you also increase the risk that you're going to have a patient having pain during the procedure. And so you can end up having pain and hypotension at the same time. So my approach is that I'm going to hit them with a hammer with everything I've got in the spinal so that I've done everything possible to make sure that they are completely comfortable during the surgery. And if I have hypotension, I'll deal with it, right? But then I've only got one problem. I'm not trying to manage two separate issues at the same time. So that's my approach. And so the doses that I give are sometimes a little bit bigger than what other people are going to give. Um, but that's sort of the art of anesthesia. And everyone's got their own decision-making tree about how they go about that. So I'll give you guys kind of like a dosage range and just understand that my doses are at the high end of the range. And there's some other people who would rather give a little bit less of a dose. That being said, typically what I put in my spinals, I put 1.5 milliliters of local anesthetic, whether that's going to be 0.75 bupivacaine or 3% chloroprocaine, depends on the facility I'm at and how fast the OB is. If they're an hour door to door, I'm going to use chloroprocaine. If they take an hour and a half to two, maybe a little bit longer, I'm going to use the 0.75 bupivacaine. You can add 5 to 10 mics of Precedex to that, and you can add 4 to 8 milligrams of Decadron to that. And so the reason for giving those two medications, those two adjuncts, the Precedex, again, it's really good at taking care of that visceral referred pain when they extrovert the uterus. It's a great anxiolytic, and at either of those doses, you're not gonna sedate the patient, but it's just gonna help them be calm and relaxed during this intensely stressful thing. I can't imagine being wide awake and feeling things inside me. The other really thing that these two medications do is reduce shivering. And we've all been in that position, right? The baby comes out, you start the Pitocin, they start shaking so hard that the blood pressure cuff won't read, the pulse ox is useless, they can't hold their baby. And so it sounds like a little thing to say, oh, it takes away the shivering. But it actually makes a profound difference in your ability to monitor the patient and the patient's experience as well. So the other drug we haven't talked about yet is Decadron and putting that in a spinal. The number one most important thing is that you use the preservative-free Decadron. It comes in 10 milligram per milliliter concentrations, has no preservatives. It's safe for intrathecal use. Okay. So what that does, that also will um, treat that visceral referred pain, and it is fantastic for reducing nausea. due to hypotension, and it reduces the nausea and itching from intrathecal opioids. So if you add Duramorph, and it's going to reduce the rates of itching and the severity of itching and nausea that your patients are going to get from the Duramorph. So that's what my spinal typically looks like.
All
That
right,
was
so
my
I'm
next question was that, are you still using any opioids in your spinal, or do you feel like adding the Precedex, you're able to eliminate using any opioids there?
Great point. So Precedex will give you about 12 or about 6 hours of analgesia postoperatively. The Decadron will give you around 12 hours of postoperative analgesia. So it depends, right? So this is where I no longer cookie cut my anesthesia and give everyone the same dose. If I have a patient who reports that they've had severe itching after a previous C-section, I'm definitely going to omit the Duramorph, and we may do a tap block. We may not. I did a paper with Juan Quintana and some other people, and we showed pretty good postoperative analgesia, especially if you add, scheduled Tylenol and NSAIDs afterwards. Um, and what I've found just from doing this is the vast majority probably get equivalent analgesia just from Precedex and Decadron. But there is a small percentage of the population that it's just not adequate for. And I haven't really found a good reason why, or been able to narrow down which patients are going to, it's not going to work as well for. And so I do typically add, a small dose of Duramorph in there as well for most patients. Unless I'm at a facility that has moved away from Duramorph into doing tap blocks or QL or whatever, or I've got a patient who doesn't want it because they had such a bad experience previously.
So then let's just add up the volume of that, just for our listeners to understand, because we're using concentrated vials of Precedex and Decadron, et cetera. So can you talk about, so what type of volume then are you giving intrathecally?
So 1.5 mLs of local anesthetic and 1 ml of adjuncts. So the Precedex is 100 mics per milliliter. So to give 10 mics of that is 0.1 mLs. The Decadron is 1 milligram or 10 milligrams per milliliter. So to give 8 milligrams of that is 0.8 mLs. And then 100 mics of Duramorph, and I may overfill the TB syringe just slightly, but that's another 0.1 mLs. So it's essentially 1 ml of adjunct, and anyone from 5 feet to 6 feet, I've found I don't really need to adjust my dose at all. They all just get 1.5 mLs.
So you don't see that. That's my next question uh, with giving 2.5 cc's, you don't see any higher incidence of a high spinal or anything like that by the increased volume that you're giving there.
So there's 150 milliliters of CSF, right? The difference of zero point 0.5 to 1 ml difference in 150 milliliters is pretty insignificant. The things that really do make a difference is, one, the speed of your injection. Um, that's probably the biggest thing. And the other thing, I don't know if it actually matters or just something that I've always done, is just ratchet the head up slightly. So the upper torso and neck is flexed a little bit,
Mm-hmm.
and rarely see any sort of issues.
Perfect.
I won't say never, because, we're blindly injecting neurotoxins into the central nervous system. Weird stuff happens.
Right. So I guess let's talk about this next. Now that I'm thinking about it, because I've started to use Precedex as well in my spinals for sections, and I've started to have patients that I had previously in which I wasn't using Precedex, and I've taken care of now, and I can see the only variable I've changed is adding Precedex. I haven't started adding Decadron yet. I'm really interested to potentially start doing that, but doing the Precedex, patients have told me this is so much better than last time. I'm not shaking near as bad. I can hold my baby. I don't feel the pain as much when they're sewing up my uterus. It has been night and day difference, and I can see direct. This is the patient I've taken care of twice now. But when I've explained this to a lot of my colleagues in those other facilities, the biggest pushback I get is, well, do we have an FDA approval to put Precedex in spinals? And so, what would you say to that?
The thing you have to understand about FDA approval is there are only 5 medications that carry an FDA approval for neuraxial use that we would potentially use in obstetrics. There is no medication on the market today that carries an FDA approval for epidural use. The only medication that did was called Depo-Dur, which was essentially a liposomal morphine. It was like Duramorph bound in liposomes, kind of like Exparel. It was Exparel, but with morphine instead of bupivacaine. That was the only medication that carried FDA approval for epidural use. So anytime you've given any medication in an epidural, it did not carry FDA approval. The medications that carry FDA approval for intrathecal or spinal use are 5% lidocaine, 1.5% lidocaine, 0.75 bupivacaine, and 1% chloroprocaine. Anything else you've put in a spinal has been off label. Now, and the reason for this is when a company goes to get FDA approval, there's one of the spaces is route of administration, right? And so if you put epidural or spinal on there, that is the only route that that medication can be given. And like all of our local anesthetics, all of our opioids, all of Precedex, right? There's multiple ways that we give those. And so 99% of these medications, it just says injection under route of administration with no further information about where you're injecting. It's just for injection. Okay. And so the FDA even acknowledges this because if you look at the package insert for Duramorph or for clonidine, it talks about giving them intrathecally, even though they aren't approved specifically for intrathecal use or epidural use. Okay. So FDA approval really doesn't mean what most people think it means. Now, the other thing is, so what do we have? We have literature out there, so we can prove that it's safe. In the case of Precedex, we've got tens of thousands of cases reported in the literature, all the randomized controlled trials. I mean, this isn't a new thing. This has been being done for 30 or 40 years at this point, and without a single report of complication from its use. And the ASA, the American Society of Anesthesiologists, put out a paper a year or two ago and said that, with all these drug shortages that are going on, here are the list of medications that all obstetric anesthesia providers should be familiar with in case what you're normally using you can't get. and they talked about, the drugs and concentrations and doses, and you should be able to use bupivacaine or ropivacaine or tetracaine or chloroprocaine, and talked about how to use all these different local anesthetics and in all these different scenarios. But as far as adjuncts go, they included Precedex in that list that obstetric anesthesia providers should know how to give. So you even have the American Society of Anesthesiologists endorsing its use at this point.
I think that's so helpful, especially because that is the biggest pushback I see is, well, this is not FDA approved, right? So why should we be able to do it? I think that explanation really brings light onto the subject of, for one, well, if that's your rationale behind it, well, then you need to fact check a lot of the other drugs that you're using for various things in your practice. So yeah,
Yeah, we can't do epidurals anymore.
right.
Right. Yeah, I think that's the big thing that I was thinking through is like, it seems like a lot of times that excuse comes up when it's a new thing or something that you're not comfortable seeing, and you're worried. Maybe it's the worry of litigation or whatever it may be, that I'm going to try this new method, it's not going to go well, and then I'm not going to have backing to say, well, this is why I did it. So to hear your explanation on that's really helpful.
Is there anything else that you wanted to add? I guess there's one other question I did have. Maybe this will segue into one last part. I know we're kind of running in on time here. I know you've done a study. You mentioned that earlier. That looked at this. Did you compare the results of? I know you kind of briefly talked about this, but giving Duramorph to the patients versus solely doing Precedex and Decadron, or I guess the combination of all three, or how that compared to doing like a tap block or something like that, in terms of is there a significant better option versus another?
No, we didn't compare. It was just a retrospective review because the paper was literally the first paper to discuss using the combination of Precedex and Decadron for C-section. There'd been one other paper looking at using that combination for labor analgesia. We were the first ones to look at it for C-section. And so we were just really trying to describe the technique and in a way that like let us talk about our outcomes a little bit. And so we just did a retrospective review to get the information out there quickly and easily. To my knowledge, there is not anything out there comparing. There's lots comparing like Duramorph and Tap Block, and there's lots comparing like Tap and QL and maybe ESP, but definitely not comparing Precedex and Decadron versus Duramorph versus regional anesthesia.
Well, I know I said originally at the beginning of this episode we might get into blocks or something like that. I know we're kind of running the end of time here. I guess just in like 2 minutes or less, do you do blocks for C-sections in which you can't give interaction anesthetic, or do you try to just solely stick with Decadron and Precedex? Or if you do blocks, when would you be doing that?
I do blocks for general anesthetics when we haven't done a neuraxial technique. 100%. I think that's just the right thing to do. We have the ability, and it makes such a difference in the quality of their recovery. And so 100% general anesthetics I will do. I'm of the camp. I love doing blocks. I still do intrathecal medications over blocks most of the time. And a lot of that is just due to time management. And the other half of it is, in my role as chief, trying to manage a department of people to all be equally adequate at doing tap blocks, right? Because if you've got a provider who is good enough to put a spinal in for a C-section, that Duramorph is going to work for that patient. What I really don't want happening is providers putting spinals in for C-sections and then doing a really bad job on the tap block and the patient not having an intrathecal medication to fall back on. Um, you know, and the other side of that is it's not always the provider. It can be the equipment you have. If you don't have good needles, if you don't have a good ultrasound machine, certain body habituses make blocks a lot more difficult. And so the results of your blocks are not going to be as reliable as intrathecal medications across an entire department of anesthesia providers and an entire lineup of patients, right? You just can't get the same consistency that you get with Duramorph. Now, do I think that the combination of Duramorph and a tap block is better than just Duramorph alone? Absolutely. Despite, the literature doesn't agree with that, but I think when you talk to patients, their opioid consumption may be the same, but the quality of their recovery is far better, and they're able to get up and move around with far less pain afterwards. And so whether you just do Duramorph alone or Duramorph and a block together, because I think that Duramorph is adequate in combination with multimodal therapy. Whether you add a block on top of that really comes down to combination of how badly does this specific patient need it, and do we have the time to do it, or do we have 5 more patients behind her who need urgent C-sections. And, that 5-10 minutes that it's going to take you to do the tap block is going to maybe affect some neonatal outcomes. So it's a big depends. Like I said, general anesthetic, hands down all the time. Am I going to do it for in addition to my spinal? Maybe.
Yeah, that's really helpful, and it's helpful that you can kind of get like very narrow on your thoughts of like, oh, I'm going to do this every single time, or this makes sense for every patient. But like you said, when you're thinking about a department-wide, standard of care, also thinking about other patients that are on the floor that need attention as well, it does affect the type of anesthetic that you do, and it's helpful to think of those other extrinsic factors that are going to be playing a part in that decision. So. Well, Tom, I just, for one, will say thank you so much for giving us your time tonight. This has been extremely helpful for, I know, Cole and I, and the listeners that are listening. I know you're very busy, so this has been super informative and very helpful. So I really appreciate you taking the time to do it. I've been writing notes all night. I've got a whole page full of things that I'm going to take with me. So yeah, just really appreciate it. Thank you so much.
Yeah, cool. Always good talking with you guys. Hopefully we get to do it again soon.